Sir, Funny Prashant, sir.
Madam, you are spelling as a Funny Bhushan. Is not a Funny Bhushan, no?
Hey, Funny Prashant, sir.
మీరు ఫనీ భూషణ్ అని నాకు వినిపిస్తుంది అట్లా.
అవునా బావా నా బాయ్ నా
అంటే మేబీ బికాజ్ ఆఫ్ మాస్క్ అండ్ ఆల్ దోస్ థింగ్స్
మాస్క్ నాకు నేను కూడా మొబైల్ డేటాలోనే
ఫనీ భూషణ్ అని ఐ యామ్ లిజనింగ్ లైక్ ఫనీ భూషణ్.
అవునా?
సో ఐ యామ్ కన్ఫ్యూజ్డ్ హౌ కమ్ ఫనీ భూషణ్ టు దిస్ Hyderabad Psychiatric Society.
భరత్ సార్ అందరూ వచ్చేసారు సార్, స్టార్ట్ చేయండి.
Do you think? 8:10 precise. It's 8:08.
ఓకే సార్. అంటే మన సీనియర్ మెంబర్స్ అందరూ చాలా మంది జాయిన్ అయ్యారు సార్. అది చెప్పు.
Okay. Madam, one small thing. శ్రద్ధాంజలి ఫస్ట్ లో పెడదామా మధ్యలో పెడదామా?
ఫస్ట్ లోనే పెడదాం సార్. ఫ్యామిలీ ఉన్నారు కదా, వాళ్ళని ఫ్రీ చేసిద్దాం.
ఓకే. Some of them may not join కదా అందుకోసం.
Yeah, better to complete in the initial only, sir.
Okay, sir. Right, sir. No problem.
Anil, please be ready with Dr. Dattatreya's slide.
I am already ready, ma'am. If you want, I can take a test also. You can take a test.
Allow Dr. to start, and then I'll tell you when.
Yeah, once you share done, I'll share it.
Okay, madam. I think it's time to start.
Yes.
Are we audible to everybody now?
Yes, sir. Loud and clear, sir.
Okay. Good evening, everyone. On behalf of Hyderabad Psychiatric Society, I welcome you all for today's CME program. At the outset, we would like to apologize from the organizing side that perhaps in the last couple of months, due to various reasons, we couldn't conduct our routine monthly CME. But I'm sure we are going to cover it up and do amends to our loss of time in those 2 months in today's program. We have two eminent speakers today who would be talking about a very important and practical topic of what we are going through every day. And I'm sure a lot of you have lots of doubts to ask, and lot of you may have few comments to make as well regarding the present prevailing circumstances. Now I would like to invite the president of our Hyderabad Psychiatric Society, Dr. C. Lakshmi, to come over and take over the proceedings. And I welcome you all once again. Thank you.
Thank you, Bharat sir, and welcome all members of Hyderabad Psychiatric Society, our chairperson Ram Subbareddy sir, and our two eminent speakers, Dr. Manisha Biswal and Dr. Funny Prashant. Incidentally, both are PGI products, so you look forward to an academic feast. And as we were discussing, what do we want to know about COVID? We are no longer working as primary psychiatrists. Many of us are being called for general duties as well, being asked questions we are not able to find answers to. So maybe we'll be better equipped once we are done with this session. So before we start the session, I would like to pay homage, Shraddhanjali, to our dear departed Dr. Dattatreya sir, whom we recently lost to COVID. Anil, can you please start the presentation? Yes, thank you.
Yes.
On behalf of Hyderabad Psychiatric Society, we want to pay Shraddhanjali to sir, a mentor, a teacher, a friend, a guide, and who has been in our hearts, in our minds, even when he's no longer physically present among us. Next slide, please, Anil. Dr. Dutt, as he likes to introduce himself and also likes to be called, was born in Vijayawada. He has done his post-graduation from KEM Mumbai. He was an excellent psychiatrist with varied interests. I have worked with him as an assistant professor for a few years, so I know how varied his interests are. He's also been a director, he is an actor, and he's done so many ads for the central government. And we all know his deep voice. And if you still want to hear it, he has dubbed the Telugu version of the history of Golconda, which still resounds in the world, in the fort of Golconda. And he has been associated with Kamineni Hospital since 1998. He has guided 14 theses till date. He leaves behind his wife, who's joined us, and we also and his son, I suppose. And he leaves behind his wife and two sons and many well wishers, his his friends, his seniors, his juniors, his students, of which I am also one. We miss you, sir. We wish that you rest in peace and that you will be dearly missed. But what the values you have taught us, the spirituality you bring into our lives, the love for psychiatry and MSc that you have taught each one of your students, including me, we will remember you always, and we will try to evaluate whatever you have taught us and carry your legacy forward. Thank you, sir. And if any one of our senior doctors who are present, unfortunately, we cannot give them to speak because there's a separate link for panelists. If you could put in your messages for madam and his son who's there, please type in, and we'll be sure to read it out to them, or they can read it also, as they are also one of the panelists. Now I welcome Dr. Ramasubba Reddy sir, to the chairperson for today's session, who's a professor to and introduce our first speaker. Ramasubba Reddy sir, the stage is yours.
Thank you, Srilakshmi madam. Thank you, Bharat Reddy sir. And today's topic is
And the next slide, the first speaker.
COVID-19 frequently asked questions. So I think 1 year is completed after the first epidemic. Now again, the second wave started. COVID-19 second wave has become very dangerous due to high infectivity and its mutations. In Maharashtra, second wave started with the triple mutations. All these mutations are highly infectious and transmissibility is very high. And some of the patients, young patients, are dying due to its high infectivity nature and its lethal nature. These viruses are continuously evolving through mutations to evade human immune response. When there is increase in transmissibility, it is harder to control the epidemic. Again, we have to resort to lockdowns. So we didn't expect that again second time lockdowns will occur. Some strains are less sensitive to vaccines. In such circumstances, efficacy of vaccination is questionable. In some countries, already 30% of the vaccinated population got infected. We don't know the mortality rate of this population. Even in Delhi also, considerable number of patients vaccinated got infected. One of the problem is with the new strains, mutants are not detectable even with RT-PCR tests also. So regarding the guidelines, even the WHO guidelines, they are frequently changing. Even in our apex bodies like ICMR, All India Institute of Medical Sciences, they are changing frequently guidelines. When they removed ivermectin, remdesivir recently. So the only one drug which is they are promoting as treatment is steroids. That too in severely ill patients and critical patients. So regarding these uncertainties, some of the physicians in peripheries, they are not following the guidelines properly. Some doctors, they are waiting for 1 week or 10 days to give steroids. Then what is the use of giving steroids after pathology is established? It is meaningless. Better to start the drugs. Steroids are main essential drugs based on the severity of symptoms and after assessing the inflammatory markers. So this type of, there are a lot of uncertainties are prevailing regarding the guidelines. So in this scenario, I request Madam Dr. Manisha Biswal, Professor of Microbiology, and her specialization is in the field of neglected bacterial infections like scribe typhus and rickettsias. And to her credit, Madam is having 60 publications. That shows how she is academically oriented. We welcome Madam. We are privileged to have you as a speaker today, and I request you to go with your presentation. Am I audible?
Yes, sir. Thank you, sir, for the introduction. I'm going to share my screen now.
Adil, please stop sharing.
So is it visible?
Yes, madam, it is visible.
So when Dr. Sri Lakshmi asked me to talk about COVID, instead of going in for a proper didactic lecture, I decided to take it forward in the form of FAQs, especially the current FAQs on COVID-19. I think everybody has read extensively on COVID-19, and people would not be interested in a proper lecture at 8 o'clock on a Saturday evening. So I have kept the presentation in the form of FAQs and quite general, so that generates points of discussion, and then we can move forward. So we'll see how this goes. So the question that everybody is asking is, are COVID cases declining? Everybody is hoping that the answer is going to be yes. So officially, the data that is there, that is available, that is released to us worldwide and also from India, is that we are seeing a decrease. This is May 23rd from the WHO stats. So we see the Southeast Asia, this includes India, in dark blue. So we see cases going down, so the peak is decreasing. However, this is also reflected in the apps that are showing this in the IIT Kanpur, for example, has an app called the Sutra app, which I find is pretty reliable. This is the orange is what they have predicted, and the blue is how we are going right now. So this is India, and this is for your state. So it's therefore we can look at all the other states, and it's pretty accurate. Till now, the prediction is going according to how they have predicted. However, the actual figures might be much higher. This is there from several counts. This is a New York Times review that came out very, very recently. So if we have, say, 3 lakh reported deaths, however, we might have exactly the double if we go by a conservative scenario, and much, much worse if we go by a worse scenario. Nobody really knows the number of times we have to multiply the actual figures that are reported. There is a lot of patients who are not coming for testing, and there are a lot of deaths that are not going down as COVID deaths. So we have all seen pictures of mismanagement of why this is happening. And apart from COVID, proper COVID, a lot of patients are dying out of the post-COVID complications after they are released from hospital, after they become PCR negative and going home, or to non-COVID ICUs. There's a lot of deaths that are occurring at that stage also, which it doesn't come into the statistics of COVID deaths. So the actual figures, nobody really is sure of, and a lot of people are making a lot of hypotheses. The other question that everybody is asking is how effective vaccine is currently in today's scenario with so many variants. ICMR has released this everybody knows. So these are the 2 vaccines that are available in India, Covaxin and Covishield. And after the second dose, the positivity is 0.03 for Covishield and 0.04 for Covaxin. This is the data that they have released. However, we should remember that this efficacy for Covishield is at the 4 to 6 week interval that the majority of us have got. The actual trials, the initial trials of Covishield were for a 12-week interval, and that nobody has got in India till date. They say that at 4 to 6 weeks, the efficacy is around 55.1%. It gives a 55% protection. At 12 weeks, which was the original plan, we'll get a protection of around 81.3%. So this data is going to change after they start recording infections after vaccination, and they start vaccinating people at 12 weeks as it was originally intended. In the US, they've recorded the breakthrough COVID cases also. This is for Pfizer vaccine. So they have seen 10,000 total breakthrough cases, of which asymptomatic is around 2,000, or the hospitalization is around 995, and the total number of deaths is around 160 out of the 101 million people that they have vaccinated. So there they have a breakthrough rate of 0.07%. So this is the Pfizer vaccine data that is there. So exactly what is the protective level antibody? A lot of people are going in for antibody tests. We have many such kits in the market. So this is a communication from Nature for the Pfizer vaccine, where they have studied antibody response after the vaccination. They have found a 95% probability of developing a high neutralizing antibody titer after the second dose. So it is pretty effective, and the antibodies that are there are neutralizing, and they're developing in high number of patients. This is the Sputnik vaccine. This was Lancet, pretty recent study. What Sputnik has done, Russian vaccine, is that they have used one adenovirus vector for the first dose and another adenovirus vector for the second dose. So that the hypothesis was that the adenovirus itself is going to give rise to the two doses with the different vectors is going to give rise to a much higher antibody, and they have seen a 91.6% efficacy against COVID-19. And this is the vaccine that is soon going to become available in India also. This is a 3-week interval between 2 doses. So the efficacy after a few months in India will change once we start having people vaccinated with all of these other vaccines. People have also tried the mix and match vaccines. This was a study in Spain. April 2021, they had some 663 participants. The first dose was AstraZeneca, that's the Covishield. And the second dose was the Pfizer vaccine, and they found a potent immune response, a much more potent immune response than they would have got only for the AstraZeneca vaccine. So this has yet to be published. This was a oral, this was a short communication Nature. The whole paper is yet to be published. So this antibody, there's a lot of people trying to measure their antibody to see if they're protected or not protected. Do they really need to measure antibody levels? So like I said, there are so many kits, antibody kits available in the market. And some of them validated, some of them are not validated. It depends on what exactly it is looking for. We should be looking for the neutralizing antibody for the particular spike protein that is there. And not all kits measure this. So there are people who say we should not be going in for antibody tests. But the question everybody is asking is, since Pfizer has the highest efficacy, how soon it is going to become available in India? So the Pfizer has a lot of backlog. They're saying not before 2023 or at least end of 2022 that we will start seeing that vaccine in bulk in India. Even when it comes, Pfizer has one problem of that it has to be stored in the deep freezers. So in the Indian scenarios, that is going to be a problem, a logistic problem for after receiving the vaccines and for the distribution chain, etc., etc. What about other vaccine candidates apart from these 4? There are a lot of vaccine candidates in the pipeline. So Cadila has one, Hyderabad-based Biological. Lee has 2, one with the US company and one with 2 US companies, Johnson & Johnson. Then there's Genova with another mRNA vaccine, just like the one that Pfizer developed. Then Bharat Biotech is coming with a nasal vaccine. And Serum Institute of India is also developing another second vaccine apart from the Covishield. So these are vaccine candidates, and some of them are already in the trial stage, and they will all, they propose to be out in the market soon. No, exactly when, nobody knows. So these variants of the SARS-CoV-2 virus, it's an RNA virus, and all RNA viruses mutate. So whenever a virus mutates, we will have these variants. Many variants, CDC calls them variants of concern and variants of extreme concern. So currently we are seeing variants of concern, which are some of the important ones are listed here. India is seeing the mutations, the strains that originated from India are in the B1617 category. There are 3 currently, 3 and 1 and 2. And the 2 one that is often more concerned because it is circulating very widely in India and also in UK and everywhere that Indians have gone. The problem with these variants is that they are much more transmissible. They have a mutation in this spike protein. If you see this cartoon, the red is the spike protein, which actually looks like this. And there is a mutation, a substitution in the amino acids. 2 substitutions actually, double mutant they're calling it, which cause the attachment to the ACE receptor to be much better. So it's much more transmissible. So that's the problem with this particular mutant. We will have mutants. We will be expecting to see a lot more mutants all over the world. Yes, today the paper says that Vietnam has a mutant strain, which is actually a hybrid of the Indian strain and the UK strain, originally Indian, but it also has a lot of mutations that the UK variant has. So we should be expecting a lot of these variants to come up. The problem is some of them will not cause any problem, but some of them might be much more virulent and transmissible compared to the ones. The question is whether these vaccine strains, these mutants, are going to be covered by the current vaccines that we are given. So the studies currently that are saying that they are effective. So this is a study from London. So you see the odds ratio of either vaccine, either the Pfizer or the AstraZeneca, and then you see that the odds ratios, any vaccine, single dose, double dose, they're all protective against these vaccines that have been studied, 617, 117, etc., etc. So currently at this stage, the vaccines that are available are protective against these variants, not just antibody levels, but also T cell response. So they're seeing that the variants are being covered by these vaccines. There is very good neutralizing capacity as well as FC mediated functionality for these vaccines. And what's more, it is likely to be long term. So that's the good news about vaccines. However, there are still a lot of vaccine naysayers, and currently this is the one that is trending. Luke Montagnier, who says, the one who discovered HIV virus, who says all the vaccinated people will die in a very short time. It is completely misleading. And the top immunologist of the country, Dr. Gagandeep Kang, has come out with this on her Twitter thread. She says, whenever we vaccinate people, they will develop an immune response. That's what we're hoping for. And all the immunocompromised people will, they're known to have prolonged viral replication. So in the setting of a existing immune response, neutralizing antibody, when the virus is replicating in this population, there might be more chances of mutation because the virus longer, by the property of it being an RNA virus. And then what happens is they might have mutations and then these variants, but they're less likely to go out, to be up and about and spreading this virus in the community. So the solution to this is we just have to keep on vaccinating everybody and keep on manufacturing vaccines according to the local trend. Suppose we have a mutant that is not covered by these vaccines, then just like the influenza vaccine, seasonal influenza vaccine, we need to have a strategy to quickly develop vaccines that will cover that particular mutant in the area that it is circulating. So essentially the solution is to vaccinate everybody. So I hope this is not a FAQ right now, is people asking whether they should take the vaccine or not. They should definitely take the vaccine. whatever is holding them back. This question, for example, that I will get blood clots. So the blood clots from the vaccine is 0.004%, when actual risk of blood clots from other things are more only control pills, smoking, and even the COVID vaccine infection itself is far higher than the. So any side effect that is there from the vaccines, and plenty of people have taken the vaccine now, like 101 million in the US and so many crores in India. If it is definitely causing a decrease in infection, then people should take the vaccine, no matter what the risk of the side effects are. What about reinfection? People infected in 2019 are getting infected in 2021, and there are many studies that are coming out with papers. It's all anecdotal. We don't have any large series of reinfection till any place. This paper had 4 patients, and first episode was asymptomatic. Second was 3 of them did not make it out of the 4. There are other studies that are showing that the infection is milder the second time around. So like I said, we do not have any very large data series of patients with reinfection to make any conclusions. There are papers that are going in for genome sequencing, and they're finding, is it the same strain that is persisting in the patient, or is it another patient? This is a patient from Delhi who had it in June 2020 and then again in August 2020, and they found that these strains are different. So this was definitely reinfection with another strain. So this is all the data that is coming out for whether it's reinfection or, and this was a question that Dr. Reddy mentioned about if RT-PCR is sensitive enough for the new strains that are circulating, missing people who are being picked by CT scan. And there are lots of patients. Everybody has heard about these patients. The thing is, RT-PCR by default is based on viral shedding, and that can be intermittent. So this patient, for example, was positive, was discharged, was negative, and then again came positive once after discharge, and then got antibodies. So this is a paper from Journal of Hospital Infection where they have studied all of these patients, and then you see plus, then there's a minus, then there's a plus, then there's minus. By default, with the intermittent viral shedding, PCR is sometimes positive and then sometimes negative. It takes time to come positive. It is possible that in some patients, the lung features are developing earlier than the concentration in the nasopharynx, and also improper collection and all those other logistics. It is possible that the RT-PCR is negative while it is the CTE is able to pick it up faster. However, we have yet to see a study that compares the two and draw valid conclusions. Then are there going to be next waves? Of course, there are going to be next waves. This is there for all the respiratory virus pandemics. This is from 1918, the influenza, Spanish flu that we had one peak in the spring of 1918, and then we had a much bigger peak in the October of 1918, and then it subsides after some time, and then after some, we have another very big peak. So by default, respiratory viruses, they spread to the susceptible population if they're up and about, and there are people who are susceptible. So this currently is the COVID waves that are going on in Japan. They're facing the 4th wave, which is said to be far more severe than the other 3 waves. And they're talking about canceling the Olympics because of this. And then this is Singapore. We had very less cases, but then what happened is people started coming in, and then they had imported cases, and then more imported cases, and then that led to a spike. So this, in today's world with travel, etc., once lockdowns are removed, this is going to be the situation, and this is going to be a reality. So we will be having second waves. We will be having more waves. The question everybody is asking, very scary, is that people are saying that children will be more affected in the next wave. The Indian Academy of Pediatrics says that the first wave and the second wave also, the same rate of infection as adults children had, and 90% of them were mild or asymptomatic. Some of them had pretty severe pneumonia and MISC, and they needed ICU care. It was highlighted this time in the second wave, simply because the denominator of the number of children who got infected was much higher, just like in adults. And in the second wave, we were not prepared. So all the first wave, we had very few cases of pediatrics. So in the second wave, when they started to come in, it became highlighted. It made it appear as if we have more children who are affected. Actually, same percentage of children. It is just that the sheer numbers were more. So if parents who are the vulnerable population get vaccinated and they follow good mask etiquette, hand hygiene, etc., etc., and then children then will not get the infection transmitted to them. Children above 2 years should be trained to use a mask properly. And also in the US, like the Pfizer is going in for trials even from 6 months upwards children. So we need to have same kind of trials for and see if they're effective, and then children also should be vaccinated wherever possible. Also, this is a good time when the peak is coming down to prepare for stepping up pediatric ICU, so that the referral, we have a very good referral system, and not all children have to come to the metros for ICU admission. So the CDC says new masks, the new mask policy is that all the vaccinated people need not wear a mask under so many situations. So you see the right-hand side. For the unvaccinated people, they're still under restriction for in indoor areas or in outdoor areas, for example, dining, etc., etc. So they have done this one because a large percentage of their population is vaccinated. The vaccine efficacy is 90-95%, and also to motivate the unvaccinated people to go and get shots. There are a lot of vaccine naysayers in the US. So people are asking when this is likely to have, when India is likely to have a similar policy where people can go out without masks and limited indoor settings. So kind of situation we are in right now, it is going to take a very long time, and we may not have a policy like that very soon in India. We have to continue to wear a mask. So now COVID has been, has taken a lot of patients are developing mucormycosis, which is mislabeled as a black fungus. And there is this epidemic right now. We have 11,000, 12,000 cases all over the country. We were totally not prepared for this. So they call it black fungus. It is not black fungus, as you can see. And the risk factors for this overwhelming are stage. It is not acquired in the hospital. It is there in patient houses. It is there in the air. So people who are immunocompromised in the form of having taken huge doses of steroids and having hyperglycemia peaks are at risk, and they are the ones who are getting this. The clinical picture is something like the blackening, an ash scar that is formed, so possibly where the name black fungus came from. There are advisories from ICMR as to what to do and what not to do. So the most important thing is to control hyperglycemia and use steroid judiciously. They should not be given in a tapered from the, it should be started immediately and in full dose, apart from the surgical intervention, etc., etc. The Fungal Infection Society Forum, FISF, has also come up with similar guidelines, and they clearly mention that it is not from the hospital. What you need to do is control steroids and also universal masking and discharge on advice for all of these patients who have been given steroids is to come back at regular intervals and get themselves checked so that we catch the disease early. Here, before I forget, we've seen these patients in our hospital, and the surgery is, it's a butchering surgery. There's a lot of tissue that is removed, and patients, the life of the patient, the quality of life of the patient significantly deteriorates after the surgery. We've seen a lot of these patients very depressed in hospital, and this is a chance for psychological counseling and support, very strong for these patients so that they recover holistically. This is where you all will come in. So what about infection control practices? What has changed from last year to this year? Last year we had, everybody was going in as if the virus is Ebola, with every inch of the skin covered. Now we know that this much is protective. There are lots of guidelines, both from CDC as well as WHO, that says one layer of impervious gown and the facial PPE that is important, and one pair of gloves that is required. It is not required to be completely covered, and at least in our hospital we have changed quite a lot to this policy. It is not required anymore to be completely covered like this when we are going and visiting patients. One, it significantly decreases the amount of biomedical waste generated by all the jumpsuits, which is plastic and is incinerated, and God knows what kind of damage it is doing to the environment. Secondly, wearing PPE like this makes working far easier in a tropical setting like ours than wearing a jumpsuit and covering ourselves up like this. So this year we are seeing a change. So how about home patients who are sent home and patients who stay at home? How about cleaning their homes? We get a lot of questions asking cleaning homes. Now we know that it is susceptible to a lot of disinfectants. All commonly used disinfectants are effective in killing. Simple soap and water, the alcohol hand rub. And at home, all of these disinfectants that contain bleach or phenol are effective. So people who stay at home before other people are allowed to visit, etc., after they become COVID negative. So all of these things can be used to, any of these things can be used to clean homes. It is not a very robust virus in that sense. People ask questions about when to get COVID vaccine after getting the disease. So it's a minimum of 14 days actually, but the Indian government says 3 to 6 months, and CDC recommends a 90-day gap. About donating blood, also again 15 days after receiving the COVID-19 vaccine or testing PCR negative. It's non-infective by then. Is it safe to receive packages from outside, people ordering food or anything? This has been studied now that says that it goes down in a maximum of 2 days, depending on the surface. For cardboard boxes, in which most of our deliveries come, it's like 24 hours. It's below the limit of detection. So it is pretty safe. What we need to do is to wash our hands with soap and water for 20 seconds after touching objects that are handled by other people, anyone. So that should be a universal thing. Pets, there are reports of animals being infected with COVID, animals in zoos, etc., etc. In general, the risk to animals, transmission to animals is considered to be low. We do not need to worry about that at this point. So what do we do to prevent getting infected in the next waves? Having discussed that the next waves are inevitable. So we should do what we did from the first wave itself. Whatever has protected us till now will continue to protect us. It is still a virus that is transmitted through the respiratory route. So we need to protect our nose, mouth, and eyes, and mucous membranes essentially. We need to have 2 meters distance between people. Outdoors, indoors, it's not possible, then we need to keep wearing masks. There's a very classic study from the Spanish flu where there are 2 cities, the effect of social distancing. So in Philadelphia, they did not follow social distancing. In St. Louis, they did. So you see the shape of the waves. So we had a very sharp peak in Philadelphia, whereas the peak was spread out in St. Louis. I was discussing with somebody, it's pretty impossible to have a similar study in a place like India, where we simply do not understand social distancing, and people will not follow it. From the beginning of the second wave, we have had huge gatherings. When the second wave was peaking, we've had all kinds of religious and non-religious gatherings. and we continue to have huge religious gatherings, we should be moving forward to stopping these kind of religious gatherings, whatever means, either to resolve these conflicts or to simply come out with advisories that says it is not going to be allowed and that's it. So that the third wave, at least we do not get a third wave that peaks this. We should wear mask properly. That is basic. Now, CDC says that 2 masks may be more protective than one, a surgical mask followed by a cloth mask that keeps the first mask secure, and that that prevents transmission even more. But in India, we have all these jokes and these cartoons that even if people wear the mask properly, a single mask properly, it is enough. And like I was searching literature, the anti-mask people who are sick and tired of wearing masks, they have meetings, they've had these meetings long back whenever these other flu epidemics were going on. So some things probably never change. This is human behavior. This is a basic thing, but we still have to keep emphasizing this thing that we have to wear a mask to where, who we are and where we are. That is essential. Once a vaccine, now that we have a vaccine, we have to vaccinate. On a war footing, the government of India has recently said that everybody above 18 will be vaccinated by 2020. So that means essentially a target of like 1 crore people, Indians being vaccinated every day. Currently, it is around 30 lakhs. So maybe when more vaccines are imported to India or manufactured in India, we'll be able to reach this target. And rather than app-based centralized policies, which is very hindering, we should have these outreach programs, people going out to vaccinate, just like pulse polio, etc., to reach many more people than who would otherwise reach and create crowds and clusters in vaccination centers. Testing, which is going down, should be ramped up whenever the second wave we start getting a hint that the third wave is coming. So testing should be done. Again, if people are not coming, then there should be door-to-door testing like the one that's been started in UP. Also self-testing, point-of-care tests, we should be focusing on manufacturing, validating at this point, so that that can help us in the third wave. Instead of people coming somewhere, they can test at home and stay isolated there. And instead of having macro containment policies, which affects economy and other things, we should have these very strict micro containment policies wherever people are affected, to have very strict containment policies locally. Hands should be clean. Everybody knows this, especially focusing on the areas in red. This is the one thing that the pandemic has taught us, that although nothing is in our hands, we must still wash them. On a lighter note, this is basic, and we should stick to evidence-based medicine rather than desperation-based medicine of prescribing anything and everything under the sun based on one single report somewhere in the world. Like, for example, we had ivermectin, we had so much of remdesivir, we had so much of plasma therapy, in spite of people coming out in guidelines and huge trials saying this is not effective. Doxycycline is an antibiotic that continues to be prescribed. It has no role as an antiviral. So these are the things that should be avoided. We should stick to evidence, and especially steroids, which created this artificially induced iatrogenic surge of black fungus. There are a lot of new medications. What should we do? So every once in a while, there is something that comes out, small trials, people, very few number of patients showing some sort of recovery. For example, this 2-deoxyglucose thing is actually a drug that has been tried out in cancers way back. This is in 2009, 2005, 6. The research has started. The 2-DG is something that causes a huge decrease in glucose. So it causes diaphoresis and disturbances in CNA, hypoglycemia, etc., when given in intravenous settings. Although this drug is going to be distributed in the oral setting, we do not know how many sachets will be consumed by patients, knowing that people go overboard in India. So we don't know about these medications. Similarly, there are so many homeopathic medicines that are out, and people believe, people take it, But essentially, we should be having trials for all of these medications. Maybe they are helpful, maybe they are not. However, we need robust trials for all of these medicines before we start taking them in huge numbers, like we did for steroids and all these other medications. Lastly, there's such a lot of information and some of it is not true about COVID. So the infodemic curve has to be beaten. WHO has these tips it gives in its website for navigating the infodemic, so that we don't make a mess of things. We use the things that are useful and we do not go in for things that are likely to deteriorate the situation more. So let's hope for the next few waves we'll be learning from what happened in the second wave, especially the second wave, and not making the same mistakes again. Thank you very much for patient listening, and let's discuss more.
Thank you, madam, for your wonderful, beautiful presentation, informative and crystal clear presentation. Madam also covered the statistics between the Pfizer vaccine and Indian vaccine, Covishield and Covaxin. And she also mentioned how difficult it is to carry out the Pfizer vaccine because of the difficulties in maintaining cold chain. And madam also answered regarding the different mutations. And she also covered regarding the mucormycosis very beautifully. And other new drugs like 2DG also she covered. So any questions from the audience?
Two questions were there.
Please read out.
What is antibody dependent enhancement phenomenon? Dr. Fanikant sir asked.
So antibody dependent enhancement is something that is seen in dengue, and we have these 4 serotypes. So somebody who has non-neutralizing antibodies to one serotype, if he gets an infection, a reinfection with another serotype, then this is likely to interfere and then cause a huge amount of immune disturbance after that. In COVID, we have not yet seen this phenomenon either after the infection or with the vaccine, the Covaxin, the live vaccine, or the pump vaccines. So if that was a problem, then we would be seeing a significant amount of reaction and inflammation in patients who are getting a reinfection or after COVID. That we have not seen till date. It's not unlikely to be a problem in COVID per se.
Any other question?
Other one is booster dose is required or not? If so, when? It is asked by Dr. Uma Shankar sir.
Yeah, that's question. Same also I wanted to ask. Madam, please.
So we're seeing these up till now, like I said, we've been measuring this antibody level, and that's not validated according to, we don't have a single kit that said that is going to measure the neutralizing antibodies. So there are so many parameters of vaccine efficacy. One is a T cell response, many parameters of the T cell response along with the antibody that we're looking for, whether that's neutralizing or non-neutralizing. Up till now, because of these cases of reinfection and all these studies based on antibody, let's say that the antibody level is going down, people are speculating that you might need a booster injection. Very recently, there's a study, I was not able to include that in the seminar, that says the T cell immunity is going to be long lasting. We might not need boosters. However, we will have to actually study cohorts of people who have been vaccinated and study whether they are getting reinfected or not over a period of time to have policies on booster. Currently, people are saying we will require, but we are not sure unless we have these really robust studies that are studying people real time over some period of time.
Madam, how long it lasts, madam, T cell immunity? Usually 2 years. Any idea? Cross, in cross?
No, there is some immunity that goes on for a lot of years. This is the recent study that has come out that says the T cells, so it goes into memory cells. So memory cells can stay on for years and years. So exactly how many will depend on, just like other vaccines, will depend on the population also. Mostly in general, it will stay for years, but there might be certain populations who do
So
not
in
develop.
case of COVID, we can't, we are
We
not.
can't. We have to study people who do not
Yes.
develop, say, people who are likely to not develop a B cell or a T cell immunity, like for all these patients on, say, dialysis, or all these patients with these T cell disorders, etc. And for some of these people, we might require boosters depending. So we'll have to study this. This is, I think, currently under progress in the big centers.
You know, what is the role of B cell immunity or humoral immunity in this COVID, madam? You mentioned B cell immunity also developed.
Neutralizing antibodies. So this will directly attach to the spike protein. And this is the protein that attaches the virus to the human cell. So if there are neutralizing antibodies that are circulating in the blood, they will attach to the virus and neutralize it before it is able to attach to the cell of the cell that causes the spread inside the body. So that's B cell. B cell immunity. Is that what you're asking, sir?
Yeah, same, madam. Only B cell. See, madam, after getting vaccinated of the entire population, is there any chances of getting more dangerous mutations?
Nobody knows.
Nobody
it's an
knows.
RNA virus. It can go either way. It can die out. We might have milder strains that are circulating, which milder strains, less virulent strains that are more transmissible. We might have strains that are more virulent but less transmissible. There is no way we can predict right now how it is going to go. But in all circumstances, like I said, the mask and the hand hygiene and the social distancing to protect us. So if that becomes a part of our culture, that becomes by default how we behave for the next few years all over the world, we are going to be able to win this virus, no matter what strain is coming out where.
Yes. Any questions from Pushparaj?
Sir, Gauri Devi madam asked, effect on fetus. If a mother has a COVID infection during the first trimester of pregnancy, effect on fetus if mother has COVID infection during first trimester of pregnancy. Dr. Gauri Devi asked.
So we have seen mothers being delivered, having been detected in pregnancy and sometime before delivery, and then we have seen these babies being negative also. So it is not necessary that there is going to be, but there are babies who are 2-day, 3-day-old neonates also who turn out to be positive. So the peripartum period might be a place where there is virus transmission, but natal transmission is not documented till now. We do not have cases, at least they might be anecdotal, but we do not have cases where the fetus, there has been fetal death in the first trimester like you are asking.
Madam, there was, I think there's just one more question. Somebody was asking about transmission from dead bodies. There's been a lot of,
fear is there. A lot of fear is there among the public, not attending the cremation also.
So what's your take on that, madam?
So the dead bodies, as you know, are all packed in these body bags and sent. Where there has been transmission of COVID in funerals, etc., it has always been in where funerals have been attended by a lot of people, and there has been clustering at the funeral itself, because the bodies are not allowed to be touched by even their closest relatives. They are shown the face and then it's zipped up again. And because of the sheer fear of the virus, like you said, people don't go and touch the body, whenever they attend these cremations. The transmission is because these huge number of people have gone to these funerals, and a lot of the patients' relatives themselves are positive. So the transmission has occurred during the rituals, etc. From the body per se, unless the body has been taken out and extensively touched, or rituals have been done immediately after the death, etc. This is going to be extremely rare, because the virus needs living cells to replicate. After some time, it is going to die out. It's more from living people than from dead bodies that we need to be worried about.
Madam, just one question from my side, madam. There is a lot of speculation regarding the origin of this virus. So I just want you to comment on that, madam.
That is still under investigation.
So even Dr. Fauci in US is confused. Initially, he said, no, nothing, unlikely to come out of lab. Now he's backtracked. Now he said, no, this looks like having come out of lab. So we have all these new reports coming in about some 3 or 4 doctors seeking medical attention immediately before the world came to know about the Wuhan virus. So were they infected by it, and then the virus was released, or whether all this is complete myth? And this is not a man-made virus. Till China allows the world to go and check its records and its labs, etc., we will never know. We need to have a genome sequencing of these strains with all their old SARS-CoV-2 strains that they have already stocked, that were in circulation in China at that point of time. So till then, I think this is a big question mark. I wonder if we will ever come to know the answer to this question.
Madam, another question, ma'am, from Dr. Gauridev Garu. What are the complications with vaccines if person has type 1 and type 3 hypersensitivity reactions? Should they get vaccinated or not?
So this is a common, this is the only indication where we say that vaccine should not be given is if there is a known allergy to it. So the common allergies people have are egg allergies, food allergies, etc. So those people are not advised to take vaccine.
Maybe the reaction will be more with live virus or dead virus, madam, or attenuated live virus or dead virus.
The reaction, the allergic reaction, the inflammatory reaction, if the virus replicates, obviously the immune response is going to be stronger. The virus is continuing to replicate, but the dead viruses also generate pretty good immunity because the dose in which it is given, the dead virus that is given. The problem with live attenuated virus is that just like polio, there will always be a risk of reactivation of virus strain in so currently I think they're avoiding that, is to have a live attenuated virus, is to go in for the dead virus only.
Pushparaj, no questions, no?
As of now, no questions, sir.
Okay.
There are some chats, some clarifications required in chat box. Just like a virus may decrease virulence to sustain its own existence. This is by Dr. Sirisha Garu. She
Decreases
wanted
its
to have virus may decrease virulence to sustain its own existence. Please comment on that.
We might have mutations that make it less capable of replication. We have these, deficient viruses that happen. Or then, if that happens, then the virus is going to die out itself. If there's a mutation that that causes a problem in its attachment to the host cell, then obviously it is not going to be attached to the host cell, and then it's going to, be wiped out. So that is definite possibility. A mutation like that occurs.
Yes, sir.
Okay, madam.
Questions are complete, sir. Questions are complete, sir. Yeah.
Okay. Thank you very much, madam, for answering all our questions. We troubled you a lot by asking questions.
No, sir. I think it was a very interesting session for me also. Thank you very much for having me on this panel.
Yeah.
Thank you, Sri Lakshmi.
Thank you, madam, for accepting our request to attend the webinar.
Thank you. We'll call you again if you have doubts. Thank you.
Yes, okay. Thank you.
Anil, next speaker introduction, please. Slide.
So our next speaker is Dr. Pani Prashant. He did MBBS from Usmania Medical College, 1993 batch, MD from Postgraduate Institute, Chandigarh. He completed senior residency from NIMHANS. He is a consultant psychiatrist at Chetna Hospital and is the first editor of Telangana Journal of Psychiatry. And today's topic, Dr. Pani Prashant is going to cover is challenges in managing COVID-positive psychiatric patients. And this is one of the difficult one as far as the psychiatric patients are concerned. Most of the psychiatric patients, if they are in active psychosis, it is difficult for them to follow the guidelines, maintaining physical distance and following the protocols of hygiene. All these things are difficult. When they are in institution, like with a large number of patients, like 300 or 400, unless they follow all these precautions, it is easy to spread the infection for other inmates. So everyone should wear the mask regularly, and it is difficult to monitor and secure the masks every day. So most of the patients, psychiatric patients, are having comorbidities, and most of them are smokers. I don't know, the morbidity is very high, and how the coronavirus affects these patients, we don't know exactly. Even regarding the psychiatric antipsychotic drugs, how they interact with the COVID-19 treatment drugs, we don't know. And recently, one antidepressants, they came with the fluoxamine. They gave permission to use the drug in the severe cases. I don't know how far it controls or it reduces the cytokine storm by blocking sigma-1 receptors. So now here Dr. Pani Prashant is there to enlighten us regarding these complications.
Thank you very much, sir, for a kind introduction. Okay, so today I'm not going to give you a very detailed presentation on epidemiology and other issues. Okay, I'm just going to give a broad outline as to what challenges do we generally face when we are trying to treat patients who are having psychiatric illness along with this COVID. And the first thing which I want to say is that right now, okay, the COVID is taking the front seat for all of us, and that is what we are concerned about. But likelihood that the mental health problems are likely to increase is after the pandemic comes down. There might be a huge burden in the coming days to the mental health professionals, and all of us need to be aware and be ready for this. So basically, the mental health issues, all of us know that the grief reaction, because a lot of people are losing family members to COVID. There is because of the isolation, increase in substance use disorders, anxiety, sleep disorders, depression, suicide rates, PTSD. Whenever somebody is watching somebody die and the whole of the family members, one after the other, are popping off, and panic disorders when somebody is fearful of getting an attack of COVID. But along with this, there is new onset of mental health issues, whether they are related to COVID or because of the lockdown and the quarantines or the stress of wanting to live in this condition where you might get COVID anytime, or is it due to the virus which is entering into the brain and creating a neuropsychiatric symptoms or disorder? This is something which we need to look into. And relapse of pre-existing mental illnesses, which is due to reduced access to therapeutic resources. People are not able to come to the hospitals. They're not able to visit mental health institutions. There are disruptions in therapies which have been going on because one-to-one therapies are not possible sometimes. And service provision and social supports are also not very easy. Even if, let us say, nuclear families where all the families suffering from COVID, neither of the extended family is able to come and take care of them or provide support in the same house. It's not possible. So the actual social support cut off from these people is something which makes the things more worse. Suicides, I would like to discuss about it later as to how it is going to increase, but likelihood of the socio-economic impact of the pandemic is likely to increase the suicide rates later. And other issues are related to the COVID-19 related stigma and discrimination and hate crimes as it goes on. Okay, who are the vulnerable population? If we can look at, everybody is vulnerable. Okay, in this condition, there's nobody who is immune to this vulnerability. But children and adolescents, elderly, unemployed and homeless persons, COVID-19 survivors who are having healthcare workers are the most neglected people who are need help and they're most vulnerable. And those with pre-existing psychiatric disorders are grassroots workers, pregnant women again, people with disabilities, chronic disease, migrant refugees, LGBT community, who are commonly neglected from these groups, racial and ethnic minorities. What are the risk factors? Okay, risk factors are, all of us know that if we are losing anyone who is loved ones to COVID, all of us are going to have issues. Okay, and caregivers or the loved ones. There is misinformation which is available about COVID and pandemic issues. What is right? What is wrong? What should be done? What should not be done? The steam inhalation should be done or should not be done. Is it going to increase black fungus? Is it going to reduce your immunity? Okay, a lot of misinformation or clarity of information is not there even for the educated lot to give a clear guidance to the general public. And the loss of peer support because of closure of schools, workplaces, and academic loss, medical comorbidities and uncertainties regarding what is going to be the future of this pandemic. That's a clear risk factor. And stigma, whether somebody who's getting COVID, the family is being looked at not to touch, and their prolonged isolation, social rejection. Why did they get? Okay, and then this leads to burnout. And being in direct contact with an active case and facing economic burdens is the biggest stress factor as of now. But challenges for the mental health services is going to be that right now there is a positive human resources, the infrastructure burnout. Like Dr. Sri Lakshmi is actually working in a medical facility where she's not practicing psychiatry, but she's taking care of COVID and black fungus cases as a associate in the government hospital, government sector. And where are the mental health professionals going? And it's taken a back seat whether the mental health professionals who need to take care of mental health issues. And assessing mental health issues, how much are we clear about what is the etiology of these mental health issues, and how COVID is changing the origin of mental health issues at this point of time. And this is infodemic is what it is called. Along with the pandemic, there is a huge amount of information which has come every day. The social media is filled in with WhatsApps and all the Facebooks trying to tell you what you should do and what you should not do. How India has been able to fight the first wave and how effective Indian methods are, how efficient our lives are, and how. But the second wave took us by, and we all were overconfident or we put our guard down. Okay, it is not us. It is not the virus which has created the second pandemic. It is us. We created the second pandemic, a second wave in the pandemic. So there's a lot of misinformation which is labeled as the infodemic in the social medias mostly. How to tackle that? As a psychiatrist, we have a responsibility to do away with the myths and the wrong information in the society. And access to mental health services and psychotherapy. If we are in a lockdown, the government services leave the private sector, but even the government services, the people are not able to come to the hospital. They're not able to get their free medications. There is a lot of change which can happen because they're not taking their medication anymore. Okay, and then their support systems are being pulled out. And then the public health paradox, the person who needs the most is not able to get it. Okay, the person who doesn't need it might get much more. Okay, there's a lot of injustice in what the service providing is happening. But suicide and COVID is one interesting topic. There is an increased risk of suicide. All of us know that because of the mental illness, isolation, loneliness, bereavement, domestic stress has increased because people are staying together. Automatically, financial stress is also pulling up. Alcohol consumption adds up to this loneliness. And all these factors increase the risk of suicide. But did the suicidal rate increase during the pandemic? Actually, there's a lot of studies which are showing that no, actually the suicide rates have come down in the pandemic. Maybe the what is called as the pull together effect. There are a lot of people who increase their support systems. Just being in the vicinity of people you're not able to get along with, and you're able to voice your suicidal problems, or you're getting into an argument rather than trying to end your life. Okay, so there's a lot of support systems which can come indirectly in such pandemics rather than the direct this thing, which could really. But this is going to change post-pandemic, okay, when people are going to have the long-term effects of having COVID, okay, the socio-economic impact also is going to pull on. The suicides might increase after the pandemic. We should be wary about it, and then we should be ready for this as well. Okay, challenges in psychiatric illness and treatment. This is where my role mainly comes into. Actually, when we see a patient who is having COVID-19 along with the psychiatric illness, what should we do? How to diagnose, how to go about it in the treatment. So basically the neuropathology of COVID, if you look at it, there are two ways in which the illness can affect our mind. Okay, one, the COVID virus directly enters into the CNS through the olfactory nerve. Anosmia is the first symptom, a lot of times people say. And then once it invades the CNS, the symptoms of the CNS direct invasion like dizziness, headache, psychiatric symptoms, encephalitis, and respiratory failure, all these things can cause a varied amount of neuropsychiatric manifestations. That is due to the direct effect of the virus. And then the second thing all of us talk of is the cytokine storm, how the cytokines and interleukins and how the homeostasis dysregulation leads to inflammatory response where multiple organs are affected, and then which could actually affect the brain in the similar fashion. Neurological and psychiatric symptoms, sometimes due to, as I said, direct effect of the COVID on the CNS, or secondly due to the multi-system involvement. Okay, once it affects the heart, kidneys, liver, okay, it actually, hypoxia causes a lot of issues in the brain that can lead to a lot of symptoms. Secondary to the side effects of the medication which we are giving to treat this antivirals and other steroids can themselves create psychiatric illness. Or there is a worsening of the pre-existing illness which is there, or drug interactions are also going to cause worsening of the illness, because some of the times the medication can decrease the levels of the therapeutic levels of the drugs which are being used to control the illness, or sometimes they can increase the toxic levels of the drug which is being given, which can go both ways. Psychiatric symptoms, basically in the pathology, we can understand that both the lockdown and social isolation can increase stress, PTSD, panic, depression, and psychosis. We have almost like increased by 3 times according to a lot of epidemiological studies. There's a direct neurotropic effect of the viral. Activation of the inflammatory response may increase the tumor necrosis factor and interleukin 6, which can actually directly lead to depression. So inflammatory response itself can actually cause depression by the mechanism. And where people who have psychiatric illnesses are more prone to COVID because of their lifestyle, inability to follow the SMS, which we commonly talk of, so social distance, sanitization, mask, and social distancing, and metabolic syndrome and other comorbidities which are high, and then the high rates of smoking and other substance use as well, and side effects of antivirals. So we look into this. Okay, for the challenges for the psychiatrist is to identify the cause of the symptoms. When we are called into the ICU, or okay, in a patient in a COVID ward saying that this patient is depressed, this patient is feeling very anxious, this patient is confused. Okay, first question comes to the mind is it an exacerbation of the existing symptoms, or is it a new onset symptoms? Is it due to the side effect of the drug interactions? Whether to treat it right now with a psychotropic or not, or whether to let the COVID infection come down, then we can treat these illnesses. If need to give a medication, what is a safe medication? What is the dose? These are the challenges which the psychiatrist faces. And once the consultation lies in psychiatry is another area where, okay, there's a lot of challenge in. One is you're exposing yourself to a COVID when you're working in ICUs and COVID wards to see patients. To avoid, one is to avoid a direct contact and need to be able to communicate well under even a PPE to understand the patient's psychological status. Whether they can shift it to only video consultations from the ICUs where there are more sick patients, where the exposure might be much more higher. And the moral, whether I should actually quit this job of being a consultation like in psychiatry, I sit in my clinic and see my psychiatric patient, why should I be doing all this, exposing myself? Okay, is it a moral to that? A lot of people are facing the pandemic, and once you face the exposure, you have to come back to your home, and you might have elderly family members staying with you. That fear of that moral comes into the place. Okay, and there is an increased demand. Previously, when we were in this general hospital psychiatry where I used to work in Care Hospital, Star Hospital, we used to see ICU deliriums very often, but never had the fear that we might get infected while seeing these patients. And then the second thing is that when we would see delirium, it would be easy to communicate to the family members, patients, and the work would be finished off within let's say 10, 15 minutes. You could come to a reasonable state of completing the consultation. But now once you have to enter into the PPE, wear the PPE, see the patient, come out to the family members, and again you will have to liaise with the professionals who are in the ICU to make them understand what is happening. So there is an increased demand and the stress on the consultation person, and there is a responsibility of a psychiatrist that once he sees such patients, what is that he has been seeing, what is the pattern he's seeing, and how he is treating them, and those research and follow up. This is completely missing. As you can see, even in the previous presentation, there's a lot of data which is not being researched because of the pandemic has taken us so badly, so that all of us are just engulfed by that rather than trying to look into the research. So when we look at psychiatric morbidity, the most common thing in the ICUs is the delirium, next followed by anxiety, depression, and especially in patients who have long-standing COVID. High dose of steroid use and its effects on an individual, they can be varied from psychosis to acute mania or delirium also in some cases. And as you see, the adjustment disorder, that why should I be the one who's getting this COVID disorder? I have done nothing wrong in my life. And worsening of the pre-existing symptoms. Okay. So when we see the psychotropics and the COVID, the most common drugs which are used in the COVID are, we all know the first thing which comes is the azithromycin or doxycycline, hydroxychloroquine, and then the Fabiflu, which was there in the previous. Now, I don't think a lot of people are using the Fabiflu, but Favipiravir is the one. All these three drugs can actually cause a risk of QT prolongation. There's some interferon therapy some of people have been receiving, which can cause bone marrow suppression. Lopinavir, ritonavir, these are the two antivirals. Okay, I'm not seeing them being used now, but it's being there in the literature. It's written about these two drugs are also being widely used. So they can cause cytochrome P450 inhibitors and then risk of neutropenia, and they can increase the loss of SSRIs, okay, which we commonly prescribe safely among medically ill patients. They can increase the serotonin surge and can cause serotonin syndrome. Remdesivir can be toxic to the liver. It can raise the ALT enzymes. Okay, and steroids can cause mild suppression of the cytochrome P. If we look at all these three medications, steroid seems to be one of the safer alternatives. Okay, I mean remdesivir doesn't create too much of a trouble. But what we need to be more worried about is the QTc prolongation and the cytochrome inhibition. If we look at individual antipsychotics, haloperidol, risperidone, olanzapine, quetiapine, clozapine, you can see that haloperidol can cause QTc prolongation. All the four medication, including the quetiapine, can cause QTc prolongations with the azithromycin, hydrochloroquine, and the favipiravir. And then, as I said, the ritonavir and lopinavir can actually increase the doses of risperidone or concentrations of risperidone or haloperidol inside the blood and reduce the concentrations of olanzapine. So we need to be aware. And in remdesivir, if we are giving an antipsychotic, we should be watching of the ALT levels and then see whether because all the antipsychotics are metabolized through the liver. Okay, there's nothing escape. And if you are giving somebody on clozapine, seizures and bone marrow suppression, which can happen with the interferon therapy, we need to be more clear, especially with the clozapine and hydrochloroquine. In the antidepressants, the tricyclic antidepressants with amitriptyline, clomipramine can actually have an increase in QTc with the hydrochloroquine and even with the ritonavir and lopinavir. But see now the remdesivir seems to be more safe along with the SSRIs. Okay, antidepressants, even the Fabiflu seems to be reasonably safe because the interactions are only written. If the box is empty, it means it's safe there. Okay, and the steroids are also safe for the antidepressants. Okay, even escitalopram in some of the studies has shown to be increased some mild amount of elevation in the QTc with hydrochloroquine. So the first thing which came up as the ICMR study, which was saying prophylaxis with the hydrochloroquine, take it. Okay, it is going to prevent. And a lot of us took it. I also took it in the initial phase. In the first wave, I took the hydrochloroquine. Okay, so even advising it to people who are on escitalopram, we should be a little worried. And fluvoxamine can actually increase the hydrochloroquine levels as well in the body. Except for duloxetine, okay, all the other SSRIs or the serotonin can be raised with ritonavir and the lopinavir. Okay, and then the mood stabilizers and the benzodiazepines, lithium. Okay, we need not be much scared because if you can look at it, it's not the two drugs, hydrochloroquine and the ritonavir and lopinavir, where there can be a mild increase in the QTc. Otherwise, it's safe with other medications. Valproate, again, the remdesivir is toxic towards the liver. Okay, so it valproate is also hepatotoxic to some extent. So we should be a little choosy about the dosage of the medication and check the levels of the ALT when we are prescribing valproate in such patients. And the ritonavir and lopinavir can decrease the levels of valproate and increase the level of the antiviral. So toxicity of the antiviral might increase as well. Carbamazepine seems to be a little tricky because it has multiple areas where it can actually reduce the dose of remdesivir. It can decrease the lopinavir as well. Okay, so and even the bone marrow suppression with the interferences might be possible with the carbamazepine. Benzodiazepine seems to be safer, okay, alternatives when you are trying to treat some anxiety, except in case of rotinavir and lopinavir, they don't really interact. And then the short-acting lorazepam, you can see, has no interaction with any of them. So if you're planning to give an anti-anxiety medication, lorazepam might be the preferable drug in such cases. And if you look at system-wise effects, okay, actually the first is the system, and the second is this COVID. How can COVID affect that? And then what is the psychotropics which you should be careful about, and what are the recommendations? In the cardiovascular, arrhythmias and heart failure are a possibility with COVID, so we should be careful about the QTC prolongation. You should be monitoring if you're wanting to give antipsychotic because of the thing. We have to weigh the risk-benefit ratio between the patient's general condition and how his heart condition is, and then what antipsychotic you are going to give. In hematological situation, the COVID can cause lymphopenia, thrombocytopenia, and disseminated intravascular coagulation. So drugs like carbamazepine and clozapine, we should be a little careful there. SSRIs can increase the bleeding risk, so one should be more careful about the dose of the SSRI. Should not be having very high doses. And monitoring and stopping the offending drug is what is the most effective thing in hematological side effects. Renal, COVID can cause acute kidney disease. So lithium, topiramate, and paliperidone can be a little tricky. Lithium basically because it can cause kidney issues. Topiramate also, and paliperidone is also predominantly excreted through the renal system. So one, we need to check for the lithium levels as well as the kidney function test. Respiratory failure is the major area of COVID infection, but sedative hypnotics, caution on use of any sedative hypnotics and the dose with which you need to use them. Hepatic injury, again, as I said, valproate, carbamazepine, even second generation antipsychotics, tricyclics, and some of the SNRIs, we should be a little careful in monitoring. Neurological delirium, anything which can increase the confusion like anticholinergic agents or the tricyclics, and avoid sedatives in delirium. So general rules in patients who are having, because there is no hard and fast guidelines which are there, which have developed as of now. The only guideline I could actually find in the Indian context is one which is developed by the Ministry of Family Health and Family Welfare, which is in association with the NIMHANS, okay, where they have given guidelines as to how different organizations should function. General rules, delirium, okay, with the safer alternatives are risperidone and haloperidol because of the least anticholinergic side effects. Better to avoid quetiapine when you're treating patients with delirium and COVID, because QTC interval prolongation can be higher with the quetiapine. These are the two safer alternatives is what it is. And basically that's what, it's not a preferred drug in delirium. And patients with long-acting injectables who are not able to visit institutions because of the injection process and they're not able to get those injections, whether they can be shifted to oral, if somebody is so stable, whether it is safe to do shift to oral or not. This has to be a decision taken by the clinician on case-to-case basis. Drugs like fluoxetine, fluoxamine, which can be enzyme inhibitors, should be avoided in such cases. Clozapine is in stable patients. There are guidelines about clozapine, because clozapine, a lot of times the question comes that if it causes neutropenia, okay, and then already patient is suffering from COVID, and whether we should stop the drug immediately or whether we should reduce the dose immediately. If it is a stable patient who has been taking it for a longer time, okay, and then no neutropenia has happened, okay, even they say the monitoring of the neutropenia can be once in 3 months. And then they can be stopped up to 3 months, okay, and rather than monthly once or once in 15 days. And they say that unless the patient is definitely developed a new immunocompromised state, or the lymphopenia is starting to come in, or neutropenia is not starting to come in, clozapine can still be held at the dose, or dose can be reduced to half, okay. So clozapine is still something which you should be using with caution, because these are the group of patients who will definitely decompensate, and their treatment resistant cases. You have chosen clozapine because they are not responded to other medications, you know that. And if you want to remove that balance, and then exacerbation of psychosis might be more difficult to handle in some of the patients. So A caution on waiting on the patients and reducing the dose is more suitable. And if the patient is definitely in ICU, is requiring oxygen and all, definitely you should stop them. There is no doubt about that. And antipsychotics, which can cause increase in sugar levels and cause EPS, may be not beneficial in such patients. Benzodiazepines, if you are wanting to use lorazepam, is a better choice, as I said already. Long-acting benzodiazepines are better to be avoided. Okay, and then the other challenges which we are going to face as a psychiatrist in these COVID times is relapse due to non-compliance. Basically, non-compliances are very high. As such, we are when we are practicing in a regular way, also the non-compliance is high. But because of the COVID situation, there's a lack of access to healthcare. I think Dr. Umashankar can talk better about this, how he has been facing in the general hospital as a superintendent, how much there is a patients are suffering, what has to be done to get these patients back to track, and lack of access to buy these medications, and patients who are risk of suicide, overdose, and absconding in severe illness, how to handle those patients. If a patient is stable, we generally continue the same dose, and tapering should, whenever a patient is being stable and let's say antidepressant has to be tapered off after 6 months or 9 months, I generally say that let this COVID pandemic be over, then we'll try to withdraw rather than trying to withdraw at this point of time and putting you at a risk of having a relapse. So a lot of patients are very unhappy that I don't want to reduce the dose of the medication, but I think that's a decision all of us should look into as a clinical challenge between the patients. As Dr. Ram Subbareddy was pointing out, that there is a key challenges which are faced by mental health service providers in the government or the public sector or the private sector. First is to difficulty in isolating or quarantining patients with active symptoms. When somebody is coming into a psychiatric facility, okay, with an acute psychosis or an acute manic episode, how do we actually isolate them or quarantine them? Okay, and patients with psychiatric disorders, by virtue of their symptoms, may not cooperate to even test them for the COVID test as well. And when we have to hold the patient, we have to inject the patient, the staff has to pin them down. Okay, that itself increases the close contact, which we can't really avoid. And some patients might be even uncooperative at times, become hostile towards the treating team. So safe distancing, keeping them at a safe distance is not a real possibility. And let us say somebody who is homeless person and with a mental illness is brought to the mental health without an ID card. How do you test them for COVID? Because an Aadhaar card number is completely compulsory required when you're trying to test for this thing or any ID. In patient settings, the difficulty when agitated patients is to maintain the norm of the sanitization, mask, and social distancing. As I said, the screening of the patients before admission. Let us say we actually, even at Chetana, we try to do this. We test all the patients who are admitted at the time of admission with initially we were doing antibody tests. Now we are doing rapid antigen tests to see whether there's any positive. We had people who come with acute manic episode. Okay, they were tested positive with the rapid antigen test. We had to send them back saying that we can't take in patients because we don't really have an isolation wards, and that we don't have staff which is equipped to handle COVID along with the psychiatric illness. So we had to send them. Okay, but next day they came up with an RT-PCR showing which is negative. So now where do we put them? Do we take them in, monitor them, or put them in isolation? How do we go ahead whether they have, should we consider them that they have COVID or not? These sort of challenges becomes very difficult to handle in our mental health institutional setups. And let us say one of the patient develops COVID in a general ward when we are trying to keep, we are not having isolation. People can't afford to, a hospital is not all single rooms. Okay, there are dormitories, there are single rooms. So if somebody who is living in a rehab, let us say within a dormitory develops COVID, what to be done to all the other, how do we tackle such situations? Facilities. So we are lacking in general hospital, like let us say we need an emergency oxygen and other medications. Our staff is not generally equipped or trained to do all that. ECTs, I think all of us have to stop giving ECTs during a wave, but once it's gone, then testing, sanitizing the trolley every time, sanitizing the mask after or the oxygen ambu bag. How often can we do all that when we are having to give 10 to 12 patients an ECT? Okay, this is the guidelines which suggested, let us say if a person with a mental illness with COVID-19, RT positive, PCR is positive, then what do we do? The guidelines suggest that all patients who have mental illness with COVID positive for being admitted to any institute or any place have to be assessed by a mental health professional within 24 hours of the admission. That is what is the guideline talk about. Okay, this is a possible way to look at it. Let us say if they're very agitated or risk of suicide or violence, they go into an ICU setup and the risk is assessed every 12 hours. And if they're okay, then they're shifted to normal ward. Let us say the psychiatric symptoms are in remission and are on regular medication. You don't do nothing. You just continue the same medication. If the, let us say the worsening of the symptoms is happening, then what choice of medication, depending upon what treatment for COVID is going on, what is the drug-drug interaction, you need to look into it and then try to adjust the dose of the medications. And we should always monitor for side effects in a regular manner. So the other area of challenge for psychiatrists is the mental health faced by the frontline care workers, where the morbidity of anxiety, depression, insomnia, and traumatic distress is very high. But the predominant risk factors are increased contact with the affected individuals, prior history, quarantining themselves, and poor support. Whereas protective factors for such frontline workers has been access to PPE kits. Initially, there were a lot of frontline workers who did not really have an access to a PPE kit, and they were still forced to work in such environments, which actually make them more predisposed. Stress. They felt that environment is not supporting them. Access to psychiatric services, if it is good, and adequate time off from work, like they're worked in shifts and then they take off between for different people take off at adequate times, it can actually be more protective. So the pandemic affects the whatever is happening due to the pandemic. A lot of people are forced to stay indoors. Okay, people who have had marital discord or family discords, okay, they are having to live in the same room every day, more hour of time spending together. That increases domestic abuse and substance abuse. Social isolation is something which all of us are facing, that we are not able to go to the, at least to attend an HPS meeting in a hotel. I think they made a previous attempt last, 2-3 months back, where they booked a hotel and then they tried to invite at least minimal number of people. See, there's a feel in all of us to meet people, talk, and then sit. Okay, that if that is missing, all of us might go through depression or feeling locked up a lot of times. Health-related anxiety and problems due to the information which is coming, which is not clear. There's no clear research. There's no clear data. Yeah, ICMR says hydrochloroquine is used for prophylaxis. Now, initially Fabiflu was used. Now, remdesivir. Now they say remdesivir is also out of the list. Okay, so what to believe, what not to believe? Even from the scientific community, we are not really getting proper responses. And accessing the treatment, as I said, because of the psychiatric illness, patients who with psychiatric illness have poor physical health and lower life expectancy as such, and they do not report symptoms very accurately. Family does not ensure much of a compliance, cannot access healthcare due to logistic reasons. And these are the people who might not be really comfortable with the telehealth services. Okay, the telehealth services has grown, but it is not something which, okay, this sort of population is likely to use. And because of the long-term socioeconomic effects of the pandemic, grief and loss, unemployment, economic recession, loss of opportunities, a lot of people have lost their jobs, stigma of the COVID, inability to perform the last rites according to their one's religious views. All these leads to a lot of stress, and the pandemic, I think the mental health pandemic is shortly going to happen, is what my feeling is. There's a lot of solutions which have been suggested by a lot of people. They talk about telepsychiatry should be encouraged and promoted by the government institutions. NIMHANS is promoting it, but clinicians also should encourage their patients. On one side, the telepsychiatry is a very good way right now because of the mobile phones and then the WhatsApp calls, and a lot of people are doing offhand telepsychiatry because of the, even now there's a lot of allowances which are given to a doctor, saying that yes, you can reach to a patient through a mobile, you can reach through, talk to WhatsApp, and then try to prescribe through online and send the prescriptions online. Okay, but how much ever it is giving on the other side, okay, it is losing that some of the patients are not really comfortable. They say it's not like talking to you, coming there and talking to you, sitting with you, understanding things in a more clear fashion. So even the patients who are doing the telepsychiatry would want to come and see the doctor at least once in a while. Okay, so there are problems also that the rules and all the confidentiality and okay, whether the medium with which you are doing the telepsychiatry is something which can actually is end-to-end encrypted, is what WhatsApp says. But are we actually following the guidelines which we should follow for telepsychiatry? That's some area which we need to look into. And the main role of combating the infodemic, as the madam actually has said, what are the steps on trying to control the infodemic? Okay, checking your sources, going back on what is right and what is wrong, taking opinion of doctors and other learned people. So combating the infodemic is also a responsibility of the psychiatrist to remove the stigma and myths which are coming into the health issues, especially around health issues and here in the general population. And general well-being with good diet, exercise, yoga should always be promoted. Having a good routine on a daily basis is something which should always be told to the persons, people who are trying to tackle with the pandemic. And screening for common mental disorders should always be done. And routine psychiatric evaluations for those severely affected with COVID or on a high dose of steroids. Whenever the patient is in, one is that when patient, a psychiatrically known psychiatric illness patient is getting admitted in a COVID ward, they should be evaluated within 24 hours. And any patient who is going beyond a particular long time and they're getting high dose of steroids, they are getting into ICUs, they have been there for a long time, all these people need to be evaluated even though there are symptoms are not present. Okay, they need to be evaluated to see for any symptoms which are coming up. Early identification of psychiatric disorders by integrating with other disciplines and educating the your colleagues is something which you should always do. And drugs should be used judiciously and considering the drug interactions. And counseling of the ICU patients who witness deaths is also very important. With this, I say that all of us are fighting the pandemic on our own levels, but this is something which we have to do together and we can only save lives together. Okay, with this, I thank you, the HPS, for giving me an opportunity to talk on this interesting topic. Before I end my topic, okay, I wanted to talk about Dr. Ram Subbareddy said that fluvoxamine has been given this thing, double-blind placebo control trials has proven that it can reduce severity of the illness in COVID-19. Yes, it has been there, especially about the sigma-1 receptors, which Dr. Ram Subbareddy was talking about. But okay, at the same point of time, okay, the research which comes along with, like even remdesivir was supposed to be very effective in initial first 1 to 7 days of the illness to reduce the viral load. Now people are contemplating whether it is really there or not. Okay, if sigma-1 receptor is the only one which is responsible, fluvoxamine is a promising drug. Okay, we can look at it. Okay, and then there have been double-blind control trials which have been very positive. So we can look forward to other areas. Even chlorpromazine has been shown to reduce the effect of COVID infiltration into the lungs. Okay, so there are some positive effects on antipsychotics and okay, fluvoxamine especially. That there's a good news with most of patients who are taking those drugs that their likelihood of developing COVID is less. With this, I end my topic and thank you for all to patiently listening to me.
Thank you, Prashant sir, for your excellent presentation. We covered all areas, psychological, social, and financial implications of the COVID-19. And definitely the anxiety levels are rise among the public. And some of the patients, they committed suicide. I think at this point, there should be a crisis intervention. We don't know when they came to know they are positive. COVID-19, some of the patients, they committed suicide. So this is a very sad thing. And so you covered very well all the drug COVID complications and its drug interactions, how the drugs rise, increases the other systems and QTC prolongation, liver enzyme increases, all those things you covered very well. When you covered all the drug interactions also, COVID-19, HCQ interactions with psychiatric drugs and psychiatric drugs. Thank you, sir, for your excellent presentation. Any questions, Pushparaj Garu?
Sir, there is a question by Dr. Sirisha Garu that antipsychotics have protective effect against COVID. Your take on these studies, please comment. Sir, another issue is point on clozapine develops side effects. Please advise regarding switch or cross tapering.
Thing is, I just talked about in the last ending part of it that yeah, there have been some studies which show that yeah, sir. Okay, chlorpromazine, okay, is known to actually prevent okay, reduce the entry of COVID inside the lungs. Okay, attachment of COVID into the cells. Okay, is
there any mechanism for that? Any mechanism?
I have not been able to. There have been multiple mechanisms proposed, sir. Each paper has its own theoretical this thing. Even with the fluvoxamine, there have been 5 mechanisms which have been proposed why it is effective, sort of a thing. It reduces the lysosome breakup. It prevents the attachment to the ACE receptor.
Yeah, lysosome and
Yeah,
platelet
sigma-1
activation.
receptor. Yeah, so there are a lot of
Yes,
mechanisms
right.
which are proposed. Okay, so whether we actually are looking at serendipity or whether it is a real research mechanism which has, okay, because in US they have done, okay, they have put 100 patients on fluvoxamine and 94 patients who are not on a placebo to see, and patients who are on fluvoxamine did not require oxygen support. Okay, which is a very great input.
Yes,
There are studies, but mind you, we are studying hundreds when millions are getting affected. Okay, so whether we are actually looking at a drug which is definitely going to help or not, because there are mechanisms which are proposed, there is some scientific evidence which is there, we should give it a try, because whatever works in this pandemic, okay, to help patients, we should try them, is what my understanding is. But giving chlorpromazine to patients, it itself has a lot of side effects. So what we should be thankful is most probably schizophrenia patients who are on chlorpromazine are likely to have a lesser COVID infection because of that. The other thing is clozapine. Clozapine is something which there are no clear guidelines as of now, but there are one paper who talks of whether if somebody who has been stabilized for more than 1 year, okay, and they have not developed neutropenia even once in the monitoring system, these people are safer. Okay, they can continue clozapine even while getting treatment for the COVID. Okay, that is one thing they talked of. Having said that, okay, even in patients who are normally getting monitored every month, these are the patients who can get monitored once in 3 months and they don't need to be monitored rigorously as other patients. There are other patients who are within the 6 months of starting the clozapine. You have just started clozapine, you're titrating the dose, and they're still 6 months and you have not monitored them adequately. There, if you're having that to continue the medication or to change over, it is better to change over the medication. Okay, so that the chances that the neutropenia can happen and cause immunosuppression in such a patient is something. Then we just slowly titrate the tape over and crossover, and tape over is the better mechanism. And somebody who has COVID and who is getting oxygen or getting into an ICU, clozapine has to be stopped. There is no other option at that point of time.
Any questions, Suraj Garu?
Sir, complete, sir. No chat box as well as question answers also clear. One more, sir. One more has come just now. Sir, agitated patient apart from.
Sir. Okay. Agitated patients apart from plain haloperidol or any other option, considering the fact benzos have to be used cautiously. See, the actual fact with the patients who are agitated, okay, the best chance we have for an injectable is haloperidol at this point of time. Okay, and if we are putting them on oral, risperidone is the next option. Olanzapine can also be considered. Okay, quetiapine, okay, maybe we should better avoid because we really don't know how it's going to interact with other antivirals. Benzodiazepines, yeah, the best is to still use lorazepam if you are able to see that the saturations are not affected and then the patient is still, okay, there is infection, the patient is getting treatment, but the saturations have not been affected and the respiratory distress is not there. Lorazepam could be a choice in such patients.
And one more question from Dr. Ashok Kalinchandani, sir. Question and answers, sir. Should
people have become immune to that?
Yeah, people are becoming immune in a way to the news of death all the time. So stoicism has become a very way of coping with grief. Can we not expect this to continue post-COVID too? And therefore, we need not worry too much about the suicide rate. I don't know, sir. Actually, it is not about. I don't feel the suicide rates are going to go up because you've lost somebody and you're having a bereavement. That is the reason you're going to. I think it is the implications of the life after the pandemic. Okay, how your socioeconomic impact is going to be, whether you will be able to pull up yourself, your social systems and support systems are going to come back to line, and then how your quality of life going to be after the pandemic. These are the factors, and then how stressful it is going to be, how long this is going to continue. Okay, there's a lot of skepticism which is dissatisfied. We don't have answers ourselves. Okay, when is this going? If somebody asks me, patient comes and asks me, doctor, karnallo aipotundi kada idanta malli man normal aipotham kada mask teeseyochu kada. Okay, we really don't have answers there. Okay, once this second wave goes, what happens next? We still are just silent spectators at this point of time for a lot of questions. So I think what you said makes sense, but still, I think there are a lot of other reasons why the suicide rates might go up. post. What
think
the papers are talking of is that the mental health issues right now don't seem on the front, but once the pandemic comes down, the mental health issues become the predominant area where it might become an epidemic by itself, sort of a thing.
Given the financial implications are very serious.
Sir, one more
So
question by Dr.
no
Fanikant, sir. One more question from Dr. Fanikant, sir. Use of zolpidem alone or in combination with melatonin in case of insomnia infected with COVID?
Yeah, there are some positive reports about melatonin. Okay, zolpidem is also a short-acting drug. Okay, you can use it. There is no problem there. Okay, some cases talk about melatonin having a positive effect in COVID patients. So there is no this thing. Why do you want to combine both melatonin and zolpidem? Because it's available as a combination, or you want to try one after the other? Okay, better is to initially try zolpidem if you are more comfortable. It's only a mild insomnia case. But whenever patients have insomnia in such situations where there is an infection and COVID sort of a thing, anxiety is a predominant thing. Okay, using a small dose of a benzo might really help in such patients, or a low dose of an antipsychotic might help in patients calming down. Okay, rather than trying to just give them a sleeping pill in that sense.
Sir, one more question, sir. How about topiramate as a substitute for lorazepam in respiratory distress? Topiramate.
I think topiramate. I think it is to. It's an antipsychotic used in the ICU setups, if I'm right. I think he's talking about the topiramate.
Yeah, Dr. Ashok Alichandani, sir.
Yeah, I remember. Okay, so I think you can use topiramate, okay, in cases where you're requiring sedation instead of lorazepam when there is a respiratory distress. That's what I was talking about. Using haloperidol or a low dose of an antipsychotic might be much better rather than trying to use a benzodiazepine in such cases.
Pushparaj, any questions?
Yes, sir. Topiramate అనేది an antidepressant anxiolytic with no sedation. Separate question, sir, by Dr. Ashok Alichandani, sir. An antidepressant anxiolytic with no sedation.
And I answer చేశాను అన్నదానికి.
information.
Okay, fine. So that's good enough, sir. Okay, I have not used topiramate, so I'm not really sure about it. But okay, if you feel it is a good antidepressant, okay, which can be used.
Another is
trazodone. Yeah, I've seen another question: how to handle ADS withdrawal in COVID ICUs? Okay, fine. So the rules of handling any alcohol withdrawal, okay, especially in patients with COVID or ICUs where there's a comorbid this thing, it's always between the lorazepam is considered a better drug in such cases. If you're using a benzodiazepine, chlordiazepoxide or diazepam is not really, especially because you can give it in parenteral form. Okay, it has always to look at what is the general condition versus how much of the alcohol is contributing to the withdrawal, is contributing to the delirium, because a lot of times delirium tremens can happen. And if you don't give lorazepam, it is going to be more difficult to handle. And especially if, let us say, somebody who is on a ventilator with bedazolam infusion or something, I think it is usually handled. But even now in ICUs, okay, people are trying to talk about lorazepam being a better drug than midazolam in handling patients who have had alcohol, okay, along with the delirium and in the past, alcohol dependence in the past, along with developing COVID infection and getting into an ICU. Okay, so lorazepam might be the better drug. Okay, and the general rules of any withdrawal is what one should follow.
One more question. What is the role of grief therapy?
Yeah, definitely. Okay, so that is where I'm trying to come to, is that all of us actually have to focus on these issues in patients who have lost. All of the psychiatrists, maybe most of us are receiving cases where one or the other family member is lost. Today I saw 3 patients where, okay, they lost people to COVID and then they were in a depression. Someone was in a panic attack, the other was in a grief. Okay, other was in a dilemma whether to tell his mother or not. Okay, so definitely grief therapy, bereavement therapy, supportive psychotherapy. We need a lot of psychologists, psychological help, in patients who have gone through COVID. So there's a huge dearth there. I think a lot of times even our other colleagues also try to counsel them as much as they understand, but definitely most of them need our help.
So clear, sir. Questions are clear, sir.
Yeah.
Yeah.
Thank you, Pani Prashant, sir. If there are no questions, we will end the session now. Okay?
No questions, sir. No questions, sir.
No questions.
You,
We will end the session. And I thank Dr. Sri Lakshmi and Dr. Bharat for giving me the Bharat.
Thank you, sir.
There, Sri Lakshmi Bharat is there?
Yeah.
Yeah, both
Yeah.
of us are there, sir.
Madam, would you like to say something?
I want to thank both the speakers. One speaker I've already thanked on WhatsApp. I want to thank Dr. Pani Prashant. He's the person to go to when you want a complete academic presentation. He's the person to go to. And he never says no, no matter what the crunch, what the time of, how much time he has to spend, he never says no. So very heartful thanks from us, sir. And it was a very informative presentation. Thank you so much. And Ram Subbareddy, sir, thank you so much for chairing and adding so many inputs from your side. Thank you, sir. Bharat, sir, you please take over.
Before we conclude, we thought that as members, we would like to present our respects to departed soul of Dr. Dattatreya by maintaining a 1 minute silence from everybody. I know it's going to be a bit odd to do that on online, but perhaps this is a beginning, which perhaps would touch wood, we don't need to do it again. But as a respect to the departed soul, shall we? I would request you all to maintain a 1 minute silence. Thank you. Thank you very much. Now we would be concluding our CME program. I'd like to thank the chairperson for today's program, Dr. Ram Subbareddy sir, and two speakers who have done an excellent work today to enlighten us on a very important topic. I'm sure you are all enjoyed today's academic feast. We'll be coming forward with some more in the coming months. I thank you one and all for attending this program today. Thank you very much.
And last thanks to the Crescent also for making it very smooth. No glitches anywhere. Pushparaj Garu, thanks a lot for your cooperation. And we look forward to more of your support in future also.
Thank you, ma'am. And thank you for giving us the opportunity from on behalf of Crescent to all the HPS members. Thank you, ma'am.
Thank you. Thank you, members HPS, and good night and have a good weekend.
Thank you.